Thanks very, very much, Abigail, and a very warm welcome to Karyn Casey up in Gauteng, where I believe it really is very cold and chilly. But from a very smoky Cape Town, but something, a little city that is starting to recover from the devastating fires, etc., they've just really recently had. A very, very warm welcome to you, Karyn. Karyn, I know we worked together at the Healthy Aging Society when we presented the conference up in Johannesburg, so it's wonderful to see you again, and certainly wonderful to be able to do something like this, particularly for people that we believe really need this type of extensive expertise and professional advice. I'm sorry once again for my Andy Warhol kind of camera thing, but it's sorry, it hasn't been sorted out yet, but it will be shortly. So, but I really just would like to introduce Karyn Casey as a speech and language pathologist in Johannesburg, South Africa. Her work combines running a multidisciplinary private practice, a mentor for students in speech and language pathology discipline, delivering a wide range of training workshops for ICU staff, care facilities, and fellow rehabilitation professionals. Karyn has a special interest in swallowing disorders within the adult, pediatric, and neonatal population, and is part of a local, national, and international multidisciplinary team addressing the needs of these patients. Karyn also works within a community-based brain injury rehabilitation program. She's a presenter at a number of workshops and keynote addresses at local and international conferences on the subject of swallowing disorders, voice disorders, adult neurological rehabilitation, and cognitive stimulation. She has participated in a number of international conferences on neurological rehabilitation and dysphagia, including the annual European Society on Swallowing Disorders and the United Kingdom Swallowing Research Group meeting held annually in London. Most recently, she presented at the World Congress for Neurological Rehabilitation held in Mumbai, India. Karyn is a director of the Healthy Aging Society of South Africa. I'm delighted to hear that it's still going, where she heads the Allied Health and Multidisciplinary portfolio. Her primary clinical interests are in the areas of adults with a range of neurological or neurogenic disorders of speech, language, and swallowing. She has a specialist involvement in the rehabilitation of dysphagia and research interests in the relationship between cognition and dysphagia in dementia, as well as in motor neuron disease and dementia. So Karyn is the only advanced vital SLIMS speech-language pathologist practitioner in South Africa. She's having completed her primary training in the USA in 2008 and her advanced training in 2010. She provides vital stim therapy to a number of patients within her private practice. Karyn serves as a mentor for vital stim practitioners in South Africa. She works within the aged community following her international certification in 2013 as a cognitive stimulation therapy facilitator. Karyn, thank you on the thank you on behalf of Dementia SA and the many people that are associated with our organization and who go onto our YouTube channel and who certainly are, I know, going to be benefiting enormously from this topic that we've been wanting to present for a while in the form of a webinar. So enormous gratitude and thank you so much. Warm welcome to you.
Thanks, Karyn. I think that COVID can't be thanked for many things. I can't think of one good thing to say about COVID, but certainly if we could look for the positive in it, I think it's that it allows us opportunities like this to reach out to people who are many thousands of kilometers away sometimes, and to be able to share information that we would perhaps otherwise not have had access to. So I'm very pleased that I can join you from Johannesburg. I'm sure many of you are in the Cape, but I'm very pleased to be able to join you from Johannesburg today and to be able to speak to you on this topic. It's something that I'm particularly passionate about, I have spent a long time in my career, certainly, working with people with dementia and their swallowing difficulties. And as Karyn said, it's one of my research interests. So it is something that I feel very passionate about. And I hope that today I'll be able to give you some information that you can take home to your own unique situation that I'm sure you're facing at home. So let's get going. Let's just quickly talk about what dysphagia is. And I think we all understand the ability to swallow. Nobody really questions the ability to swallow, and we kind of think of the ability to swallow as being, a reflex. But it's certainly not just reflex-based. You can also control your ability to swallow. And so dysphagia is a disability or a difficulty in swallowing. Sometimes people may only experience this as an occasional difficulty. Sometimes it can be a more persistent difficulty that can go on for weeks or months or even years. And certainly we see dysphagia in our practice occurring at any age, but obviously it becomes more common as people age and as they develop different diagnoses. So swallowing problems don't just occur in dementia, they also occur in Parkinson's disease, stroke, motor neuron disease, brain injury. We certainly see swallowing difficulties in people, for example, who've had their tongues removed for cancer or surgery to the head or neck. So today, obviously, I'm only speaking about dementia, but you can understand that the swallowing difficulty can be pervasive across a number of different diagnoses. In terms of what a swallowing difficulty looks like, it sounds like it should be obvious, but sometimes it can be disguised. It can be disguised as a person saying they've got pain while swallowing, which we call a dynaphagia. It can be the complete inability to swallow, just unable to swallow whatsoever, or the sensation of having food getting stuck in your throat or in your chest. Many times when I ask patients, what does your swallowing difficulty feel like? They always point to their throats and say, there's a problem here in my throat. Or they may say that the food gets stuck behind their breastbone. You might find that the person is drooling, which is very often a sign of a swallowing difficulty. Being hoarse is also another sign of a swallowing problem. And certainly because the voice and your swallow kind of happen in the same neighborhood, they can sometimes be related. We might see people bringing food back up and regurgitating or vomiting, having heartburn or having food or stomach acid coming back up into the throat can be an indication of a swallowing difficulty. Unexpectedly losing weight, which I think we see particularly in the older population and people with dementia, is very often a symptom of a swallowing problem. Coughing or gagging, which we often most see sort of in the late stages of dementia, and I'll get into that a bit later, but that idea that you cough when you swallow, you choke when you swallow. But remember, that's not the only symptom that we're looking at if you look at this list here. And even something very subtle, such as a person saying to me, well, we just cut our food into smaller pieces, or, I don't give my husband certain foods anymore, can very often be a symptom that something else is going on. And you're just cutting up the food, but actually what you're doing is trying to overcome a much bigger problem. So when we talk about how common it is and overall why we care about it, as dysphagia clinicians and speech pathologists, we have a really thorough understanding of dysphagia, of swallowing problems. And you see these wide estimates in regard to just how many people with dementia experience dysphagia. There's really no clear answer. You can see the incidence is anywhere from 13 to 57%. And that probably has something to do with the various etiologies of dementia and various stages of decline. And we do know that just about half of persons living with dementia, living in a healthcare institution such as an old age home, have swallowing difficulties. So no matter what numbers we pick out, sorry, I thought there was someone there. We can all pretty much agree on this undeniable fact that dementia is a process that disconnects individuals from the world around them. And all of these activities that really made them start to be stripped away by the disease process. We also know that eating and swallowing and meal times are really activities that provide us as human beings with connection and dignity. And while, of course, we care about the first point of minimizing adverse health outcomes, we understand that people with dementia are more likely to experience malnutrition, aspiration pneumonia, but also we need to have a good understanding of what's going on, because the better we can treat and maximize swallowing abilities within individuals with dementia, the greater our impact in terms of helping them maintain dignity and connection. So I want to just pause for a moment, because the next couple of slides are extremely information heavy. I recognize that it's going to be information heavy, but there is kind of a method to my madness here. So what I want to show you is two charts, and I want to just orientate you on what it is that you're going to be seeing here. So what you're going to see across the top of the chart are different domains, and we can call them different areas that influence eating and swallowing. And then the rows down the side are going to indicate disease progression. So we've got early stage dementia, middle stage, late stage dementia. And we're going to look at just how heavily interconnected all of these pieces are when it comes to assessing and treating swallowing with individuals with dementia. So I want to start about cognition. Cognition is our thinking, our brain power, as it were. And I want to talk about how cognition influences eating and swallowing with this population at a mild stage. And what we typically see is a mild impact in terms of attention, concentration, self-awareness, insight into deficits. With Alzheimer's type dementia, it's more of a classic memory loss early on. A person could forget whether or not they've eaten. It's harder then as a speech therapist maybe to tap into cues in order to help them utilize safe swallow strategies if that's what's necessary. But when we look at Lewy body dementia, for example, it's really very different. In an individual with Lewy body dementia, cognition can be all over the place within an hour, within a day. It's much more typical to see wide fluctuations in cognition and even things like hallucinations. So these can be a major barrier to safe and efficient swallowing for these individuals. Vascular dementia, on the other hand, typically you have preserved verbal memory. You've got preserved memory of your words, but your executive dysfunction, your problem solving, your logic, even in the early stages, those difficulties are notable. And as the dementia progresses, as we understand, so does the degree of cognitive impairment. So even at the early stages, we see deficits in memory and concentration, which impair a person's ability to cognitively concentrate or attend to the task, the actual physical task of eating. And this will also heavily influence how a speech therapist puts together their treatment plan as the disease progresses. If we're looking at someone in the middle stage of dementia, they typically still retain some of these long-held memories, which we could tap into. But as we progress to late-stage dementia, people become severely impaired, disorientated, and not really able to communicate much outside of their behavior patterns. And that's something I'm going to come back to. Let's talk about the sensory system and perception. We see taste and smell dysfunction. Even at the early stages of dementia, people have disorders to their taste and smell abilities. And this can have a detrimental impact on their ability to partake in eating and swallowing, not only because they lose interest in it, it's no longer enjoyable, or it's less of an enjoyable task as your smell and taste disappears. And it's pretty solidly recognized in the middle stage of dementia, at least, and very impaired by the late stage. And this is where we see individuals with dementia of various types showing preferences for sweet foods or salty foods, which can sometimes make us cringe as families. We see things like they want to put sugar on everything. And as we reach the middle to late stage of dementia, it's something that actually we could potentially capitalize on, because you could continue to promote oral intake in patients who are deteriorating. In the early stages of dementia, it's also very common for individuals to experience grief surrounding a new diagnosis. It might be kind of like a denial depression. And we know that depression can decrease your appetite. So in the middle stage of dementia, that's really where we see these behaviors starting to have a significant impact on swallowing. In the middle stages, behaviorally, we might see people wandering or anxious, angry, irritable, having outbursts, things like that. And it can have a significant impact on your ability to sit and participate in a meal, but also even their ability to participate in therapy. As patients lose their ability to communicate verbally and to make themselves understood, they often start to communicate more with their behaviors. And just like cognition, we see a mild impairment in the early stages, and the peak of the impact is in the middle stages in terms of swallowing. And then it kind of wanes off. By the time we reach late stage dementia, often these folks are so impaired and just totally dependent on others for everything that the behaviors are no longer really the primary barrier to safe and efficient swallowing and eating. So, and we see that pattern with a few of these domains we're going to cover. In terms of feeding and oral care, we can also see that there is a similar deterioration across both of these areas. Early stage individuals can feed themselves, and although we do have some research from early stage Alzheimer's that show us that even in the very mild stage of the disease process, individuals are more likely to receive prompting or cueing from their partners at mealtime than people who don't have dementia. So without even realizing it, you might be doing something to help your loved one eat at meal times. But as that dementia progresses in the middle stages, what we often do is we collaborate with occupational therapists to integrate adaptive equipment, different setups, and look at different ways in which we can help maximize the individual's independence. The research shows us that as long as we can maximize or maintain an individual's ability to be independent with a task like feeding themselves, we may be able to actually decrease the severity of adverse health outcomes related to swallowing. Because dependence for oral care, in other words, you need somebody else to brush your teeth for you, that has a direct impact on the health of a person with dementia. Diminished oral hygiene, the inability to look after your own teeth, increases your risk of aspiration pneumonia. And we can talk about that a bit more later if anybody has any questions about that. So I wanted to paint a picture of how many things actually affect a person with dementia. We haven't even discussed how people with dementia actually even swallow. I really want to challenge you to think of sort of swallowing and dementia a little differently. We've looked at cognition and sensation, behaviors, their feeding, the oral care, and their influence on swallowing. And now I want to talk about the ability to actually meet the nutrition and the hydration needs and how that changes as the disease progresses. I think we all have a solid understanding of the fact that this is one of the primary areas of concern for people with dementia. But we less often focus on some of the influencing factors that may change the ability to meet nutrition and hydration needs. So let me unpack what I mean about that. Early in the dementia process, the primary barrier to meeting nutrition and hydration needs is most likely related to depression. There may be a barrier due to those attention deficits that I spoke about, just not being able to attend to the task of eating, or even impairments in their taste and smell. But as people progress through the dementia process, or as they continue to deteriorate, that then changes. And understanding and managing dysphagia in people with dementia, I always say, is a moving target. We have to be flexible, we have to be fluid to reach these people in a meaningful way. When we reach the middle stages, instead of things like a poor appetite from depression or from having a mild attention impairment, it's really more of a barrier of the inability to attend to the task of eating. So we look at how we can maximize this person's ability to attend to the task of eating, and perhaps look at the behavioral patterns and how they are communicating with their family or with their carers via these behaviors, and how we could change the pattern with something like a snack, for example, which could be a way to address the inability to attend to the task of eating. So wandering around sometimes can be the most common thing that we see in people with middle stages of dementia, but that's also when their nutrition and their hydration start to drop off. So if a patient is constantly walking around restless during meal times, expending more calories than they're taking in, when they have these kind of anxious behaviors, but also decreasing their intake, that's when we have a larger mismatch. And we need to address that. So something like providing a snack that they can carry with them while they're wandering around could be one potential way that we could address the mismatch. We need to maybe move away from the idea that meal times are something that happens 3 times a day, sitting at the table with a knife and fork and a plate and your best crockery. And that maybe, you know, as the dementia progresses, it's more about snatching opportunities for the person with dementia to eat, even if it doesn't seem to be a traditional time of day to be sitting down to cornflakes or a milkshake. And then when we reach the late stage of dementia, it shifts again. It's no longer really behaviors or attention that are the main barrier preventing us from meeting nutrition and hydration needs. Now it's something that we call oral apraxia. And that's just a fancy medical term, which means that the brain and the structures for eating, like the lips and the jaw and the tongue, no longer communicate with each other. So the mouth may work well for something involuntary, like swallowing saliva or yawning, but there's a decreased ability to accept a bolus or a mouthful of food. So at this stage, you know, we might look for things like tricks almost to get the mouth open so that they accept the mouthful of food. We might try techniques such as one bite of preferred food, followed by a bite of something that they've been declining, followed by actually an empty spoon with no food on it whatsoever to get the mouth open and to trigger the next swallow. And I think what's important to mention here is we look at the importance here of self-feeding abilities, because we know that a person who feeds themselves is more likely to have an automatic response of opening their mouth, accepting the mouthful of food, and encouraging the chewing phase. When we reach late stage dementia, of course, nothing always works consistently. And that's this idea of a moving target. We need to understand how the disease progresses and how our targets and approach needs to shift, because our goal to meet nutrition and hydration also shifts. We understand barriers exist along the way in meeting these goals, and the barrier at the early stage of dementia is very different to the barrier at late stage dementia. We need to constantly shift and adjust in order to help people meet their needs. And that's why I keep talking about this moving target idea. Another area we don't often think about or isn't really talked about when you go and see your geriatrician or GP is autonomic function. And at the early stages of dementia, this isn't a big deal. So you may not have heard about it. And even at the early stages, there's actually not a big discrepancy from people with and without dementia. Although I should say that if you're working with somebody who has Lewy body dementia, the esophagus becomes involved a lot earlier than other etiologies. So your autonomic dysfunction is all the things that you don't have to think about controlling, like your esophagus. You're not sitting here right now thinking about how your esophagus is currently working. You're also not thinking about your blood pressure. You're not thinking about how much saliva to produce. You're not thinking about how often to breathe. Those are all autonomic functions that are being taken care of by your body. But in terms of a person with dementia, this is where we start to see impairments come in this autonomic function. So we see problems with esophageal dysmotility, which is really means that once food is swallowed out of your mouth, out of your oral cavity, and it reaches the esophagus or the food pipe, its movement slows down. And then as dementia progresses, your salivary flow decreases, which is another autonomic dysfunction. And so food is literally too dry to be swallowed. And that obviously negatively impacts the swallowing system. You'd also see the impact of side effects like medications that are used to treat cardiac dysfunction or sleep or bladder problems or even anxiety. Those medications can have side effects, including dry mouth, which is really significant for somebody who has dementia and is unable to swallow. There are sprays that you can get, which are called artificial saliva, which is not somebody who's now donated a bucket of their saliva. It's actually saliva that has been manufactured, a saliva type substance that's been manufactured. And using a spray like that might, provide a bit more time for that person to have a safe and functional swallow and maintain their ability to have consistent oral intake. And changing the consistency of foods, making them sloppier or providing a sip of liquid between each mouthful of food can go a long way towards overcoming the difficulties experienced by a person who's got a dry mouth. I want to talk quickly about visual perceptual abilities. It's not the domain of a speech therapist, but certainly in the early stages of dementia, we start to see changes in visual processing. And again, it always starts a bit earlier with Lewy body dementia, but by the time we reach late or middle stage dementia, at least, these people start to have tunnel vision with a decreased ability to see very far in front of them at all. So at most, maybe 14 to 24 inches in front of them. And by the time you reach late stage dementia, that's now been reduced to about 7 to 14 inches in front of them. And why is this important in swallowing? Well, especially in the earlier stages, think about the way in which you're interacting with a person with dementia. You're assuming they can see you. You're assuming they can see what you are feeding them. But how are they processing that information? And in the middle to late stages, it might even affect something like how you set up their plate. You might have like a high contrast dish and a simple colored placemat. So maybe something that doesn't have little flowers or butterflies on it, because that person may perceive those little patterns to be insects. And that can be very distracting for a person who has dementia and who's trying to eat and thinks that you are feeding them insects. So maybe a bright red bowl or a bright red cup. So we compensate in the environment for this deterioration in their visual perceptual processing abilities. And I think maybe who knew all of these components could even impact feeding and swallowing? I think we often tend to put each of these things in silos, but to truly take a person-centered approach to dysphagia care, especially with this population, we need to see how all of these things work together. So a speech therapist really needs to assess all of these domains and look to see how the barriers are shifting as you progress through dementia. I think there's also a sense that the swallowing difficulties in people with dementia are grossly underdiagnosed and at times very poorly managed. The general consensus really is that individuals with dementia, and also you as their caregivers, are making these tiny little adaptations over time. And they're so small and so gradual that people with dementia themselves very often don't even realize that they've got a swallowing problem. Like I said, you might have been chopping up his food for ages, or not giving him toast anymore because he coughs on it. So these individuals very often don't even necessarily recognize that they're experiencing a deterioration in their swallowing because you're doing such a good job of kind of hiding it. But when we reach the middle and late stages, we have lots of literature, obviously, that shows us that there's a significant pharyngeal involvement. In other words, an involvement at the top of the throat, where the food goes into the mouth and goes either into the air pipe or into the food pipe. And so when we reach the late stages, there's a highly increased likelihood of aspiration, which is food going into the air pipe. And that causes all sorts of complications like pneumonia and malnutrition and dehydration. So in terms of what to do about these things, it might mean taking all of these ideas and putting them together might mean that you would turn off the music in your dining room, or even turning it on might be a strategy to help someone with dementia eat and swallow better. For people who are still living in their own homes, you'll have more of a knowledge of the way that person used to eat. Did you used to eat together in front of the TV, for example? Or did you used to sit outside on the patio to eat, or in the garden? For someone who's moved into a care facility, it can be a huge adjustment to suddenly find yourself forced to eat in a dining room, surrounded by other people, being forced to eat food you don't like, and then being unable to communicate that dislike because of your advanced dementia. You know, if a care facility was serving sausages and that's not the kind of food you eat, your inability to communicate that may be interpreted as a difficult or obstructive behavior. And this is very often what the nurses or caregivers report. He's being very difficult. He doesn't want to eat this, or she won't eat her Brussels sprouts. Or I can tell you, if you put me in a care facility and try to feed me Brussels sprouts, I wouldn't eat them either. It's just not what I eat. And so I think if we consider the wide range of changes that a person experiences due to brain failure or dementia, it starts to make sense why every aspect of life starts to change, especially something like eating and swallowing, which are surprisingly complex tasks to have to execute. I understand all of these things that I'm talking about now are really maybe just putting a band-aid on the problem, and sometimes a band-aid is exactly what is necessary. Band-aids don't always fix the problem. They're meant to modify performance, and we can do that, and we should do that at every stage of the disease process. We as speech therapists should be involved earlier. The earlier we become involved with individuals with dementia, the greater the opportunity for rehabilitation. And not only just talking about a preventative approach, but how we could really maximize the functional reserves of each patient. And the earlier we get involved, the more receptive and able a person might be to respond to exercises and therapy. It's so rare for speech therapists to be involved at the early stage. And typically we aren't involved until there's a crisis. Of course, when somebody has an aspiration pneumonia and they're in hospital, that's often when we are called. So if you take away anything from this presentation, it would be that I hope you find a way to get a speech therapist involved a little earlier. In our last couple of minutes, I just want to mention feeding tubes. We always get to feeding tubes at some point, the discussion, the debate, the guilt maybe that people feel about putting in or not putting in a feeding tube. But when it comes to advanced dementia, the expert consensus across all the literature is not only that feeding tubes are not beneficial, but that they are harmful. And I'm happy to discuss this at a later stage if need be. But despite this, they're still used a lot. And I think this speaks to the fact that speech therapists are involved too late. When families have reached crisis mode, that's when the feeding tube goes in. And there's so many steps before that where we can get involved and communicate this information and help train people on things like careful hand feeding instead. So I know it's a lot of information to kind of take in. We've kind of talked around some of these compensatory treatments and talking about, the environmental thing, maybe changing the diet, changing the equipment you're using preferred items, different strategies in terms of how to feed people, changing maybe even, the time of day that you're eating. For yourself how things may change around 5 o'clock in the afternoon. A person with dementia experiences that sundowning effect, and now you're about to sit down to your main meal of the day. And it's very difficult to get all this nutrition into this person in the evening. So it may mean something like having your main meal at lunchtime so that you can get the majority of the calories into somebody earlier in the day so that you're not reliant on the main meal being in the evening time. And I'm happy to talk through individual situations, and if you've got specific questions related to your own environment, I'm very happy to discuss these in the question time that we've hopefully still got ahead. But I understand that each person is unique and each environment itself is unique. So yes, I know that it's a very sort of bird's eye view of this whole thing, a very quick talk, but I hope you do understand that speech therapists really do play a critical role, a meaningful role when it comes to swallowing problems and dementia. And I think despite the unique challenges, we really can make such a meaningful change for people with dementia and you as their carers across this time in their lives. So thank you very much for listening.
Thank you so much, Karyn. I'm going to unshare your screen if that's okay. Are you? So that's terrific. And a big thank you to everybody who has sent in questions. I'm going to read some of them off now, Karyn. And if we have time to open up to the floor, then we will. And my apologies if people have sent in questions and we don't get a chance to get to those. Okie dokie. So we have one question, and this is from Carol Poole. It says, my husband, Alan, who has a very slowly declining dementia, has for years had some problems with eating, which may be related to swallowing issues. And I wonder if Karyn may have any input on this. For years, Alan has had some problems with coughing and when eating, and this is getting worse. I find it extremely distressing. Sometimes when Alan eats, he has some kind of coughing fit. I consulted some years back with the then GP who thought Alan had an extremely sensitive throat, possibly related to medication he takes. And the GP suggested we try using a Symbicort 160 4.5 inhaler. I was never quite sure whether or not this really helped at all, but persisted with it for some time. I have not been able to make any connection between what Alan eats and the coughing fits. It does not seem to make any difference whether he has a soft food or hard food or toasted cereal or soup or anything else. The coughing fits do not happen every time he eats, but the frequency and intensity of the fits are getting worse. Sometimes when he coughs, it's almost as though he is actually throwing up something he has eaten, and there's a lot of phlegm with it. In addition to this, I've noticed over the last few months that he has more saliva or spit in his mouth than is normal. I don't know if he is producing more saliva or not swallowing it normally. What I do know is that often I ask him a question and he opens his mouth to answer and it's full of saliva and he has to try swallow before answering me. If possibly, she says, if you could shed some light or suggestions that he may be able to alleviate these problems.
Right, so the red flags for me in that question are the fact that he produces so much saliva and that he seems to be more mucousy. It sounds like a mucousy thing. And it doesn't seem to be particularly related to one or other kind of food. One of the things I spoke about was that esophageal dysmotility. In other words, the fact that the esophagus, instead of squeezing like a nice firm python, is now like a wet sock. It's got no squeeze in it. It's got no vomit left in it. And when that happens, the typical symptom we see is that a person starts to produce a lot of saliva, a lot of mucus while they are eating. And it's the body's natural response to this mouthful of food that's now stuck inside the esophagus. So the body recognizes that this is a highly abnormal situation. You've now got your food pipe and something is stuck in it. And the person can appear to be gagging or choking. All of the saliva is starting to pour out. The body is pushing that saliva out as a way of either getting rid of what is stuck, in other words, making a person vomit from the sheer volume, or making it wet and slimy inside the esophagus so that the stuff can slide down. So in this person, I would look at the rate in which they are being fed. We're used to kind of sitting down and kind of wolfing up something quickly, before doing something else. In a person with esophageal dysmotility, they very often need time. They need time to swallow each mouthful, and not just swallow out of their mouths, but swallow out of their esophagus. The esophagus needs to empty. So the mouth looks empty. The esophagus is still busy with that bolus of food. So the timing of the swallow, it has to be exceptionally slow. And so you might alternate a little sip of liquid just to get that person to swallow again, or put a dry spoon in their mouth to swallow again. Because what the esophagus needs to do, it needs to do another squeeze and another squeeze and another squeeze. And because the esophagus is not squeezing anymore, you almost need to trick the esophagus into squeezing. So what I often do is put a dry spoon into somebody's mouth. It makes them swallow, and that makes the esophagus give it another go, have another shot at it. So I hope that answers the question. I'm happy to take more questions from this person offline if that's not working for them.
Absolutely. I will let Carol. Carol, I think, is on, so she can, I'll share your email afterwards. Okay, then we have from Lynn, says, how best can I assist my mother with swallowing liquids? Also, taking her pills, which can't be crushed at night, is a challenge, often causing her to cough, choke, and aspirate. She would like to drink fruit juice or water without the drama. And yeah, so that's from Lynn.
So I think pills are a universal issue. You can be 17 years old and have no dementia whatsoever and absolutely gag and choke and swallow, trying to swallow your pills. So pills can be universal across the ages. So, and then if you develop dementia at a later stage and you're not good at swallowing pills, it becomes even worse. So my advice for all pills, where possible, is to have something heavy to take the pill with. I don't mean concrete, but what I do mean is that you take the pill. It can't be crushed. Absolutely, I understand it cannot be crushed, but you swallow it with a mouthful of Ultramel or double thick yogurt or something creamy, like a big mouthful of chocolate mousse. And essentially, you're tricking the brain at that point, because the brain cannot differentiate between a pill and a mouthful of yogurt. It sees them as kind of all one related thing. And so very often the throat takes both of those things down together. You'll have experienced this for yourself as well, even if you don't have dementia. You'll have put a pill in your mouth and taken a sip of liquid, and the liquid has gone down and the pill remains. Or if you're very unlucky, the pill is now stuck in the back of your throat and you're gagging and you're coughing. It's hugely unpleasant. But if you take it with something thick and heavy, typically both of those things go down together. The brain cannot discern between the pill and the yogurt and just senses it all as a solid, and solids must all go down together. Whereas if you take the liquid with a pill, the brain says, right, I shall take the liquid down first, thank you, and the pill remains behind. So try and take it with something that's almost acts as a carrier. In the US, they have gels that you take your pills with. You put your pill inside like a gel and you swallow the gel. We don't have anything that fancy here, but I think a double thick yogurt or Ultramel custard or something very creamy and thick works just as well. In terms of drinking liquids themselves, I know that liquids are very challenging, and it makes sense, right? Because if I take my cup of coffee now and I pour it out on the table, it's going to go everywhere. It's going to spread all over my desk. The same thing happens in the throat. If I pour liquid into my throat, it takes up every little nook and cranny that it can in my throat. And one of those nooks and crannies could be my air pipe. However, if I take a spoonful of yogurt and I put it on my desk, it's going to go plop and it's going to stay in one position. Well, you can't have all your liquids thickened. Some speech therapists do that. I find it to be very unpleasant, and most people do not actually comply. So what we find works better is that if you give people liquids with bubbles in them, liquids with bubbles travel down the throat in a different manner to, say, plain liquid. So in other words, sparkling water travels down the throat a little slower than plain water does. I always say to people, champagne goes down better than wine. So it goes down slower, it goes down differently, it creates more sensation in the throat because of the bubbles. So I would suggest to that person trying to change the fruit juice into maybe something with bubbles. So a sparkling thing, maybe like putting the fruit juice into sparkling water, for example, or adding soda water to a cordial, rather than just giving them a plain liquid or a plain juice or whatever.
Great, that's incredibly helpful. Thank you for that. So Chris has written, my wife complains that she is drooling and is slimy, but she drinks with a straw. She will not drink from a cup or a glass and cannot eat solid food. I have to liquidize her food before she will eat. The doctor has checked her mouth and throat and done x-rays and some other tests, but I can't find anything medically wrong, and the conclusion is that her problem is part of her Alzheimer's disease. I squirt water in her mouth from time to time. I do not know what else I can do to make her comfortable. Do you have any ideas?
Okay, so I think that the preference for certain foods is something, you know, like I spoke about, that changes over time. And so people prefer things that they don't have to spend so long chewing. And sometimes it can actually be easier to get down a mouthful of soup than it can be to get through, you know, a mouthful of lettuce, for example. So if those textures, if those liquidized textures are better for this person, I would absolutely stick with that. I'd probably not look at changing that, because you can get a lot of nutrition into a soup that you can't otherwise get onto a bowl or a plate of food. You can hide all sorts of vitamins and minerals and carbohydrates and proteins in a bowl of pureed stuff that you can't hide on a plate. So it's a good way of getting the nutrition in. And I would say to this person, don't worry about that. That's okay. In terms of drinking from a straw, that's also absolutely okay. The sliminess, again, might be related to this esophageal dysmotility. In other words, this food is sitting in the esophagus and the body is creating saliva and slime to say something has gone wrong. So what this person might want to do is try and alternate again a mouthful of food, wash down with a little sip of that liquid that they're having, and then a mouthful of food again. Just see if that helps, firstly, in terms of the hydration, keeping this person's mouth feeling a little bit more comfortable, but also stopping them from producing all of the saliva. People with dementia tend to swallow less. They're not making more saliva. They're just swallowing less than they used to, less often than they used to. And so this drooling, and even the awareness of drooling has a huge impact on a person's ability to control their own oral secretions.
Thank you. Okay, I've got a few more, so we're going to keep on going. So Magda has written that her husband drools if she doesn't tell him to swallow. Why is he doing that?
So again, it's this apraxia or agnosia. So what you're seeing is sort of an inability to get the brain and the muscles talking to each other. So agnosia can sometimes be an inability to recognize objects, and the inability to even recognize a spoon or recognize a cup. I had one patient, I'll never forget, who thought that spaghetti was worms. So very often you have this inability to even recognize the saliva in your mouth. You may feel, if you're particularly anxious, that this is poison, you can't swallow it. So all sorts of behavioral things start to come about. And then the apraxia, the inability for the brain and the mouth to start talking to each other and to communicate effectively. So this person is swallowing less often than they used to. And yes, you may have to say, swallow again, just swallow your saliva, swallow your saliva. Sometimes doctors give a few medications that help to dry out saliva. I'm always a little bit wary of that, because it's very hard to get the balance right between having an overly dry mouth and then being unable to swallow at all, and having just enough saliva in your mouth. So just be careful of medications that you get told will dry out saliva. They also have effects on your cognition, your brain function, and they can make you more prone to falls. So it's always a dangerous one. But I think to tell your husband to swallow more often, as sort of frustrating as that is, if you just understand it's not within his control, it's not because he wishes to drool, it's just that he has very poor awareness of what is going on in his mouth. He has a very poor awareness that there's even a need to swallow.
Okay, thank you. I've got 3 more questions. I see we've got 10 more minutes. Forgive me if anything is being repeated. I'm just going to read them verbatim. So do our loved ones forget how to chew or swallow? I find that my mom would chew on meat, so chicken, fish, or salmon, and then take it out of her mouth because she couldn't swallow it. I've resorted to blending food in a NutriBullet or blender stick to improve the consistency of the food may be more easily consumed. Her porridge that she eats for breakfast has so much milk, it can be considered a beverage. Is it possible that they don't want to eat or avoid eating because of the struggles with chewing?
So the forgetting how to swallow is a real thing. You know, it's again, we don't call it forgetting, we call it apraxia. So we say that the person that has dementia sometimes cannot get these muscles to work together like an orchestra needs to work together to play the perfect song. These muscles cannot work together to make the perfect swallow. And so you do end up having to blend the food. You do end up having to put things into the liquidizer and just turn it into a milkshake or turn it into a smoothie or a soup. The person does forget to swallow. It is literally a connection breakdown between brain and oral structures that results in a person probably just sitting with food in their mouth. And again, one of the tricks that works with that is maybe to bring the spoon to the mouth or to put the spoon in the person's hand and let them bring it to their own mouth. Because that simple act of just putting a spoon in your own mouth triggers something very deep in the brain in terms of, aha, I know what I have to do now. Now I swallow. So very often just having a spoon pushed into your mouth doesn't do it. You might want to actually try and put your hand over their hand and get the spoon to the mouth and see if that doesn't help the swallow to trigger for somebody who's sitting with the food in the mouth. So yes, forgetting how to swallow. It's not that they can't be bothered with the chewing process anymore, it just becomes too onerous. It's that there's a breakdown, this apraxia, this motor planning breakdown that occurs between brain and mouth.
Okay, terrific. So Lynn has asked on the chat, could you elaborate on why a feeding tube at a late stage could be more harmful than helpful?
So typically at a late stage of dementia, I'm going to go purely on what the research says. This is not my personal opinion, so this is completely evidence-based. The benefit that could be derived from a feeding tube has actually passed. So the feeding tube does not come without its risks and without its difficulties. Typically, we have to restrain people to stop them from pulling the tube out. And that's obviously very distressing to somebody to feel like they're being handcuffed or tied to a bed or having their hands wrapped up so that they can't pull the tube. The research also bears out that the longevity, in other words, the number of days that you add to a person's life by giving them a feeding tube is no greater than if you do no feeding tube at all. So the number of days you get extra added to your life are no greater with or without a feeding tube. And for the discomfort and lack of quality of life that ensues when a person has a feeding tube in those final weeks or months, the risks from things like infection, bleeding, gastric disturbances, because now you're pumping food into a tube under pressure into a person's stomach. All of those kind of medical things that then ensue are felt to not improve a person's quantity or quality of life. So we definitely, the research, and I'm happy to share articles with Karyn if she wants to share them with the database, showing that actually feeding tubes really don't improve quantity or quality of your days.
Okay, thank you. I've got 2 more questions. So we're not going to be able to open the floor, but I think we've really had what a wonderful opportunity to go in depth. So the next question is, this morning Barry was sitting with his usual boiled eggs and toast and wasn't making much progress. Then looking at the top of one he'd made to cut off, he said he's not sure what to do with them. I'm sensing this might be the beginning of issues with chewing, swallowing, and so on that many folks have, or not sure what to expect.
So that sounds like the beginning of the agnosia, not actually recognizing. I look at this egg and I'm not really sure what I have to do with it. I'm not sure how I get it out of this shell. I can see something inside it, but I can't work out how to get it from that shell to my mouth. So agnosia, recognizing or inability to recognize the object for what it is, combined with apraxia, the motor planning sequence of tasks required to get it from the boiled egg shell into my mouth. So yes, you may be looking at the beginning of this person not necessarily recognizing food and objects the way that they used to. And I would maybe go as far as taking the egg out of the shell or turning it into a scrambled egg, or, you know, even sitting with him and saying, I'm going to take the egg out of the shell for you and slice it up on your toast for you today. So they still understand that it's an egg and they still see that it's a toast, but you're kind of just taking one of the steps away maybe.
Terrific. Thank you so much. That's very helpful. Okay, so this is the last question is, though he does choke a lot more than he used to, he seems to breathe while he's drinking. Maybe that's the first time that his coordination of basic bodily functions is starting to go. Sorry, does that feel like a question? I'm just reading it verbatim. Okay.
So that makes sense, because you've got two tubes in your throat. One is for air and one is for food and liquid. And you cannot get those two muddled up. So if your food and liquid is going into your air pipe, we have what we call choking, all right? If air goes into the food and liquid pipe, well, you might have, you know, burping or some kind of gastric disturbance, but much worse in the opposite direction, right? Much worse if the food and liquid goes into the air pipe. And the coordination required to close off the air pipe and just have your food pipe opened is a very complex ballet. It's a very complex ballet with a whole lot of dancers all moving around the stage at once. And they've all got to be in the exact position. Otherwise, when you lift one of those dancers in the air, she's going to fall to the ground. And that's kind of what swallowing is like. You've got to get the timing, the choreography of all of these muscles to act in the same way, at the same rate of motion, to produce one swallow. And you do that many, many times a day without thinking. But now, when a person is breathing while swallowing, we end up getting ourselves into trouble. These people who are breathing while swallowing are typically ones that sometimes are talking a lot while eating. And that's why I sometimes say, we're not going to talk while we eat, which can sometimes be a little uncomfortable. You know, to say, no conversation now, we'll eat afterward, we'll talk after we've eaten. Because when you are talking, your air pipe is open for your voice to come out. You don't want an open air pipe and an open food pipe or food in the mouth at the same time. So you've got to pick which tube you want open, and you, during eating, you definitely don't want the air pipe to be the one that's open.
Great, that is terrific. Karyn, we've got one more question. What about agents that thicken foods? Many years ago, I used Nastrogen, not sure of the spelling, but it was manufactured by Nestle.
So agents that thicken foods and liquids, in my experience, tend to be very intolerable. So there are two products. We may have heard of one called Thick and Easy. There's another one called Nutilis. The one's a bit cheaper than the other. And essentially what you can do is you can take a glass of water and you can turn it into a thick paste by mixing in a powder. It doesn't change the taste of the water, but it changes the consistency. In my experience, people, even without dementia, do not tolerate thickened things. So if it doesn't feel like water in my mouth, I'm going to spit it out. I'm going to spit it out. I'm going to say, this doesn't taste like water. This is disgusting. And I'm going to reject it. And so for a lot of people, even without dementia, they reject the idea of having their liquids thickened. The idea of thickened liquids is around what I was talking about earlier. Instead of letting a liquid swim all around in the throat, you're keeping it in one place so that it can go down. On a sort of a thinking level, that makes sense. You know, I can understand the thinking behind it. On a practical level, the execution of it is much more difficult. When you've got a person who barely likes the taste of water anyway, and now you're thickening it to the consistency of milli-meal, it's almost intolerable. So I would rather look at other ways of getting water in, maybe something like an ice lolly that melts slowly over time and you're getting to suck an ice lolly, or you are having your sparkling liquid rather than your thickened liquid or your thin liquid.
Okay, thank you so much. That is, what an incredible webinar. And humbly from Dementia SA, I'm trying to actually put off the screen sharing so that I'm able to kind of give everybody an opportunity to say hello and to see you. Oh, there we go. Great. But just, I mean, Karyn, thank you. you know, we find that the more practical the advice and the more practical these sessions are, you know, we're all so hungry for information. And for me, I mean, a major takeaway for me is that the body is truly a magical kind of piece of machinery that operates, as you say, kind of without thought until we have to think about what we have to do. And you just broke that down into such beautiful kind of working, easy to understand pieces. So thank you so much. And thank you for your time. I'm going to stop recording and give everybody an opportunity just to say hi to each other.